This is just a quick update on some new information about how to read EDX that I've learned in the last 6 months or so, and I want to share that with you. Once again, there's a QR code, and this will be on Worcester Learn Surgery. So classification, take a look at 2015, and then the normal nerve, and you can see that I didn't have any blood vessels, oh my goodness, in the 2015 classification. And I didn't have any axons in the axonotometic second and third degree injuries. And those can recover really well, normal for the second degree injury, and variable for the third degree injury, exactly because there are some axons remaining that will collaterally sprout and support regeneration at the distal target. Now look at 2025, and you can see we have the blood vessels in there, and for the second degree injury we've got a few axons there ready to collaterally sprout and reach the target quick, and then for the third degree, more scarring, less axons. I've just got one there as a cartoon. But also you can see at 11 o'clock there's a Sunderland 0, and that's the ischemic injury. In Sunderland's big textbook, Nerve and Nerve Injuries, he described the 1 to 5 classification in chapter 9, and he described in chapter 6 everything about ischemia and ischemic block. But he didn't throw that into the chapter 9 where he put the classification. So we've added it here as a Sunderland 0, and that's ischemia. That recovery will be prompt and quite remarkable. It's like a miracle classification. Those blood vessels just come together after you release a decompression, and you get instantaneously good recovery. So here we have also the Sunderland 6, which now includes that component of ischemic block as well. Now, it's really important to understand this classification because that's how you can use the electrodiagnostic studies to know that at 3 months, if you see motor units, that implies complete recovery. If you don't see any at 3 months, but you do at 4, it's probably going to be complete recovery, but it can be moving into that third degree variable. And then if you don't see any MUPs at 3 months, that tells you it's a neurotomatic incontinuity, 4 or 2 pieces, Sunderland 5 neurotomatic injury, or Sunderland 5 Seddon neurotomatic injury. So that presence of motor units at 3 months is really important to tell you and your patient whether or not they're going to get better. So we can take a look here and look at this great relationship here. So you can see no function and then 100% function, 100% of the motor neurons intact, and then nothing as you go along that X and Y axis. And you can see that nerve function is normal until you lose 80% of the number of innervated motor neurons, and then it falls off that cliff. So that goes along with a lot of things, right? The tipping point, you're on my last nerve, the straw that broke the camel's back, and also the ability of that single motor neuron pool to expand 5 times to make up for an 80% loss. So if you look at this classification, the Sunderland 0 and then Sunderland 1 with demyelination, there's a potential for complete recovery, either spontaneously or with surgery. And then the axonotometic 2 is a very on that plateau as we're losing more and more nerve fibers. So here's the thing, the great news is as you lose nerve fibers, the adjacent axons will collaterally sprout and maintain function, but you don't know you're losing those nerve fibers. And that's why if you listen closely to patients' history, they'll say, oh, I just lost this just a couple of months ago. Especially the concept of tardy ulnar nerve compression at the elbow, an old injury, and then over time they're getting compression, they're losing axons, other axons are picking up the slack until it just gets to that critical plateau for function and you fall off that. The surgeries that we do now in many axonotematic 3 injuries would be to consider a supercharge and decide to bring you up on that plateau for critical function. And of course, if it's a 4th and 5th degree injury, then it's nerve repair graft or end-to-end nerve transfer if the muscle is receptive. So that's the marriage between the classification and starting to understand why we need to know about electrodiagnostic studies. This is a key slide that demonstrates the things we're looking at when we move now to the electrodiagnostic studies. Is the muscle receptive? Is it needy? Is it receptive? If you don't have the fibrillations and positive sharp waves, I think we all know that it's too late. But increased insertional activity is also a good sign that the muscle's receptive. And then, does it need it? And by needing it, we mean, are there no axons? Not just a complete conduction block, which we're going to talk about in a minute, but have they lost axons? So if you have a 4th or 5th degree injury where you would do an end-to-end repair nerve graft, end-to-end nerve transfer, end-to-end repair graft, then if we're going to do that for a 4th and 5th degree injury, we're going to look at the CMAP, and it's going to be NR, no response, recruitment on the EMG, NR, no response, and no MUPS on the EMG. By contrast, if we just have severely decreased CMAP or severely reduced recruitment, decreased MUPS, then that might be something that we would consider as a 3rd degree injury for an end-to-side nerve transfer. By contrast, if it's too late, then you'll be seeing that the insertional activity is gone, and you'll see notation of CRDs on the EMG, which means it's chronic and too late. So let's dig into this a bit. Electrodiagnostic studies come in 2 parts, nerve conduction studies and EMG, and we're going to go through this. We'll start with nerve conduction studies. So on the nerve conduction studies, what I look at is amplitude. Amplitude is the surrogate for area under the curve, how many nerve fibers we've got. Conduction velocity helps you localize where you've lost that myelin. Doesn't tell you how many axons are demyelinated. It just localizes for you. So, difference between conduction velocity and conduction block. Conduction velocity localizes it, and conduction block, you can see a little definition there, it implies that there's an actual clinical deficit because you're not being able to connect enough of the axons across that area of demyelination to reach the brain, to be solid on that critical plateau for function. So it implies that there's weakness or numbness, and it's secondary to focal demyelination, and recovery should return with spontaneous remyelination or a decompression. So this is something you might even sort of pause this video to look at. It's a lot going on here. There's 8 little axons there, and you can see on the far left, when you stimulate proximal or stimulate distal, you're able to pick up 8 for your CMAP, 8 millivolts. If you have conduction velocity, and we've got a couple of the axons demyelinated, then when you're stimulating proximally, you cannot get that response in the muscle distally across those 2 axons, so your proximal CMAP would be 6, distal would be 8. This is a definition. Amplitude reduced by 50% by definition is a conduction block. If amplitude is reduced by 100%, it's a complete conduction block. But you'd have weakness with a conduction block at 50%, and you'd have like complete paralysis when none of the conduction is able to jump that gap. And you can see the different numbers there for CMAPs. So you've got decreased CMAPs, but it's not because you've lost axons. It's just because of demyelination. Let's move on to EMG. So there's, again, 2 parts to the EMG, and on the left-hand side, it'll be insertional activity. We talked about that. Increased insertional activity versus slightly increased versus decreased versus absent. So right after an injury, you'll have increased insertional activity, and by 4 to 6 weeks, you'll see fibrillations and positive sharp waves. And then if you were going to have something too late, in that other column, they put CRDs. So axons are lost. We have a problem. On the right-hand side, the motor unit potentials are there. And if you've got some motor units, axons are back. So we'll talk about insertional activity now. So insertional activity is noted as normal, increased, slightly increased, decreased, and absent. I definitely have had results when the insertional activity is decreased, but it really is informing the patient and setting expectations. By contrast, if the insertional activity is absent, that's like associated with CRDs, it's chronic, it's tendon transfers, not nerve transfers or nerve surgery. This is an interesting article. It's the amplitude of the fibrillations over time. Let me blow that. So you can see that between 1 and 6 months, there's these little dots. So there's good amplitude on the fibrillations and a sweet spot between the 3 and 6 months. You want to wait the 3 months to make sure you're not doing an end-to-end operation, for example, on something that's going to get spontaneously better, an axonotematic injury. But between 3 and 6 months, great. As time goes on, and you can see that 12 months and then 2 years and 3 years, that the fibrillation amplitude decreases. You're noting the complex repetitive discharge there, and the muscle becomes fibrotic. And look on the bottom, insertional activity increased, slightly increased, decreased, and absent. So that gives us an idea about how useful that insertional activity is. Now there's 3 types of motor units. The subacute units of collateral sprouting and the nascent units over time will expand. Remember, we expand a motor neuron unit will expand up to 5 times to cover more motor end plates, and those are called chronic. So when you start to see increased duration, increased amplitude, that expansion, that means those are chronic. But the first ones out of the block are those axons that were not injured, and then they look around and they say, oh, the problem here, and they start to collaterally sprout, and we see that at 3 to 4 months, and that's why we don't operate on closed injuries until 3 to 4 months. That's why we really don't even need an electrical study until then. Because if you have the units at 3 months, the most you would do is a decompression if you found evidence of compression on examination where regeneration was stopping, for example, pressure, provocative pain over the posterior interosseous entrapment point at the arcade of Frosch. Then you would decompress there to let the regeneration continue. Nascent units, and you'll see that on the EMG, nascent units are reflected as polys, and they mean that we are now finally seeing some of the original axon regeneration reach target. The appearance of the collateral sprouting versus the nascence is the same. It's just the timing at which it reaches the target. And then over time, all of those come together as chronic. So here you go. You see the chronic, increased duration, increased amplitude as that expansion's happening. If you see polys, they'll say, well, we got some motor units here, and 25%, 50%, 100% are polys. That's great. And that means help is on the way. That means those nascent units have reached the target, but they haven't expanded yet. So they're going to expand and give us more function. The difference between recruitment and activation. Honestly, it took me a long time to get this, and this is in the earlier, longer video. But recruitment is physiological and activation is voluntary, or it relates to something wrong in the CNS. And even though they would try their hardest to give more with, say, elbow flexion, they can't because there's a stroke or there's a motor neuron problem. And as much as they try, they just can't do that. So the recruitment is physiological, and it gives you a surrogate for how strong the patient is. So mildly reduced recruitment, pretty darn good. Severely reduced recruitment, not so good. So the severely moderate and severely reduced recruitment would be on that tipping point where it's ready to fall off the cliff. NR on recruitment is there's nothing connected. So let's look at that plateau again. You can see here, we've got an injury, and these are the types of injury we know. And the potential for recovery, for example, with neurotematic 4-5 is zip without help, but the potential for recovery for the others is up towards that critical plateau for functional recovery. We call it the CPR for short because we're resuscitating the muscle, and most likely it's the same for sensory as it is for muscle, the same requirement of the 80%, 20%. We say 30% because why not? Let's just go overboard and get that recovery flat up on top of that plateau. So look below and you can see that the CMAP, which we would see on the nerve conduction studies, it goes from normal to nothing as you move from the potential for complete recovery, neuropraxia, axonotomesis, and an axonotmetic. The axonotmetic will have a full recovery, but it has to do a little work to collaterally sprout. And then below that on the EMG, what we talked about, normal recruitment, mildly reduced, moderately, severely reduced, or NR, no recruitment. So you can have a different type of injury, but on the CMAP, you would have nothing on the CMAP for the neurotomatic injuries, and then on the normal, you'd have a good number. So let's now look at some cartoon drawings for each of these injuries. So here's a patient who has nothing. That muscle is all dwindled. You can see it dwindling different, and every one of those 8 axons has been transected. So what does the EDX look like? So we're looking at this ulnar nerve, ADM and FDI, NR, amplitude, nada, nothing. EMG on this patient, insertional activity is absent. That's on that far side. There you can see CRD, so it's very chronic. Recruitment is NR, no recruitment. And there's a couple of fibrillations and positive sharp waves. That is very much on that far edge. In that study I showed you, they went out even up to 11 years or so, and occasionally there would be a fibrillation, but there's certainly not 30% of the motor end plates fibrillating to accept a motor nerve reinnervating and enough to reach the CPR. Okay, another patient. This is an example of conduction block. So is it needy? Well, if you take a look at the ADM, and you can see that it's like those little cartoons, stimulating and responding. And if they stimulate at the wrist into the ADM, they're getting an amplitude of 8.5. In general, anything over 6 is normal. But if you look at the ADM on the left, you can see that's a normal control, 8.6. But if you're stimulating above the elbow, axilla, and across the elbow, and recording distally into the ADM in the hand, the maximum they're getting is 1.6. So, a 1 and a bit axons. That's all the brain is able to access. Regardless, you can see that the conduction velocity is 39, so not bad, but the patient is really just tanked out on this, and that localizes to the elbow. Sometimes we'll see it in another EDX in a minute, but when the amplitude is so tiny, even if it is localizing to even if the pathology is at the elbow, the velocity won't allow you to localize it there. Okay, so now let's just take a look. So that this patient ADM is not needy, it just needs myelin. Now look at the amplitude on the FDI, 4.4 at the wrist and 0.8 when you're stimulating above the area of compression at the elbow. And here you can see the conduction velocity is for 48.3 across the elbow. Anything less than 50 is abnormal. But 4.4 is not normal. And if you go to the FDI on the left side, in this patient, their normal is 7.3. So what's going on here? Have they lost half their axons or almost half their axons? It should be 7.3 and it's 4.4. Or is this all demyelinating block? So how we would do now is look at this cartoon. So Noah, Llaneras, and I spent hours making this. I hope you enjoy it. So here we are, normal, stimulating proximal and distal. You're reading off of the muscle, and it's 8 and 8. So everything's normal there. in the second one, we have a conduction block on the ADM, and you've got half the axons are working and half of them not. So we've got 4 and 8. And then on the, and if you measure the distal, so if you go distally and measure into the muscle, all 8 of those axons are going to pick up. If you go proximal, half of them aren't. So here we are now with the Guyon's canal. So we've added this extra, this first blue box here is at the elbow, and the second blue box is at Guyon's canal. But if you were able to, and you can't because it twists around underneath the hook of the hamate, if you were able to measure distal to that Guyon's canal block, you would measure a normal 8. So this suggests that there's a compression at Guyon's canal. And if you look here now and look at the first dorsal interosseous on the right, the recruitment's severely reduced because there's a block at Guyon's canal and there's a block at the elbow, basically wiping out, except for one axon getting through there, not enough to give you any decent recruitment. But there's no footprint of any axonal injury at all. So this is just a conduction block, ulnar nerve transposition, and Guyon's canal release is all you need. Okay, so this is another patient. Is this patient a candidate for the sets? So if you look at the ADM and the FDI, the true axon is at the wrist, and the true axons that you can get there is not 6, it's not 8, 1.5 on the ADM and 2.2 on the FDI. So there's a few axons getting there, but not anywhere near normal. There is a slight difference between 0.7 and 1.5. So there is a conduction block. There's a conduction block on the 1 or 2 axons that are there, as represented by the 1.5. So it's not 1 or 2 axons, but it's 1.5 over a normal would be 6. And on the FDI, a similar thing. Notice that the conduction velocity here, like I was mentioning earlier, at 74, 77, that is not localizing. And if the axon number that's present is too low, then there's not enough to be able to inch along to give you that difference in the conduction velocity. So one big axon working, well myelinated, but it's only one axon. It'll give you a nice conduction velocity, but you can't localize it. Okay, so what would this look like? So distally to the muscle, like we're distal there, that's 2, so only 2 of these 8 axons are working. If you stimulate proximally, you get 2, and that's it. In the patient that we're looking at, there were a couple of axons, so we're picking up, say, 3 millivolts on the ADM, and then proximal to that, you'd be picking up 2 because one of the axons that is intact is demyelinated. All right, so now here we have that patient. Is it needy? Yes, insertional activity is increased, fibrillations and positive sharp waves are present, recruitment is severely reduced. This patient, it's needy. You've got a normal PQ, and then the profundus is down, severely reduced recruitment there. So this patient would get a nerve transfer, ulnar nerve transposition, Guyon's canal release, and when we're releasing Guyon's canal, shout out to decompress the deep motor branch all the way around until you see the flexor tendon to the small finger. Go very slow here. You don't want to get near the arch, but if you stay on top of the nerve, you're fine. And do this decompression by sliding the attachment of the hypothenar muscle off the hook of the hamate. So stick on the hook of the hamate, identify the deep motor branch proximal to the hypothenar muscle, go to the hook of the hamate, slowly, layer by layer by layer, go through the muscle fascia of the hypothenar, and slide that off the hook of the hamate, and you see the deep motor branch below. You'll never forget it, and you'll never not call it deep motor branch. And continue along until you see the flexor tendon to the small finger. That's where the entrapment point is. The people that don't get a result with the sets are not decompressing that deep motor branch. I was at a lab meeting, anatomical meeting, and there were 20-some cadavers, and I looked at I said, do this, go all the way around to the hook of the hamate, and 20-some cadavers, and 4 of the 20 surgeons there, and they're all skilled surgeons for sure, released all the way to the flexor to the small finger, and nobody else did. And then when I said, you're not doing it, do it again, then only half of them did it. So it's a eureka moment when you do this and when you see that entrapment point. And if you take an electrical stimulator and you stimulate proximal to Guyon's and then stimulate after you do that, you will see the effect of the ischemic block, if there is one, right before your eyes, and it's incredible. So this is just a summary. Fibs and positive sharp waves mean loss of axons. Increased insertional activity means timing, early axon loss. When you start to see expansion with adjectives in front of the motor units and that turquoise there, where slightly increased, moderately increased, severely increased, that expansion is meaning they're chronic motor units. Recruitment is physiological. It's a surrogate for the CMAP. It's a surrogate for the number of axons there and axonal loss. And then polys is help is on the way, is the native axons finally reaching target, the nascent axons there. So in summary, there you go. Thank you very much. And practice makes perfect. Anders Ericsson, 10,000 hours, practice it. Look at the things you don't know about. Talk to your PMRI or your neurologist about it. And thanks so much. Take care.